But welcome to Eyes on the Workforce Strategies for Recruiting and Retaining a Thriving Eye Care Workforce at Community Health Centers. And this is part one of a two-part series on building partnerships with academic institutions for recruiting optometrists. As you join today, you are automatically muted and your camera turned off. And bear with me 1 minute. I'm talking here without my slides up. Give me 1 second. As you join today, you are automatically muted and your camera turned off. Feel free to enter your questions in the chat at any point during the webinar, and we'll answer them during the Q&A at the end. During Q&A, feel free to also raise your hand to ask a question. We'll call on you to unmute your line. Today's session is being recorded, and we'll send you a copy of the slides and recording within the next few weeks. So ACU, which is short for the Association of Clinicians for the Underserved, was started in 1996 by alumni of the National Health Service Corps. Over the years, we've changed our focus a bit to improve the health of America's underserved populations and support the clinicians serving in those areas. To that end, the recruitment and retention of a transdisciplinary team is the road to achieving those goals. You can find out more information about all the different work that we do on www.clinicians.org. I'm your host for today, Luke Erdl, and I'm the program director with the Association of Clinicians for the Underserved. And ACU began working in the space of vision services within FQHCs in 2017 through helping health centers with setting up one-day vision exam events around the country. So the need was, or after this demonstration project, we noted that the need was so great that we pivoted in 2018 to providing small startup and expansion grants for permanent eye clinics, or establishing permanent eye clinics. In addition to these grants, we began providing training and technical assistance to health centers on starting up eye clinics with the support of our Vision Services Committee, which is a 20-plus member group of optometrists, health center leaders, and advocates. And we also provided this training technical assistance in partnership with organizations like Prevent Blindness, National Association of Community Health Centers, and others. Over the years we've been involved, over the years of being involved in this space, two of the main barriers we've seen health centers run into is one, the startup costs for equipment and space, and two, hiring a provider. Both ACU and members of our Vision Services Committee have witnessed many health centers purchase all the equipment to start up vision lanes and then struggle for a year or more to hire a provider while their equipment and exam lane collect dust. It's because of these workforce struggles that we created this two-part webinar series on recruitment and retention of eye care providers. Today's webinar, part one, focuses on partnerships with academic institutions to address barriers to recruiting optometrists, and our speakers, who I'll introduce in just a moment, will provide an overview of optometry training and role as the primary care providers of the eye. Then we'll dive into how both of their academic institutions partner with community health centers to provide crucial eye care and vision services, as well as train future generations of optometrists. We'll wrap up the webinar with a panel discussion on additional ways that a partnership with the School of Optometry can support the provision of eye care at FQHCs. So our first speaker is Dr. Amy Moy, and Dr. Moy is the Senior Director of Community Health Initiatives and Optometric Compliance at the New England College of Optometry, or NECO, with the goal of making eye care accessible for all. Dr. Moy co-manages NECO's extensive clinical network and relationships within community partners to provide access to eye care. She has over 20 years of experience in community health optometry and was the Director of Optometry at the Martha Elliott Health Center. As NECO's Certified Clinical Compliance Officer, Dr. Moy leads quality assurance initiatives to ensure compliant patient care. She has led curriculum initiatives at NECO to enhance student education and culturally inclusive optometry. She is instructor of record for interprofessional education and collaborative practice for optometrists at NECO. Dr. Moy is a fellow of the American Academy of Optometry and a fellow of the National Academies of Practice. She actively serves in committees for the Association of Schools and Colleges of Optometry, or ASCO, the American Academy of Optometry, and the National Academies of Practice. She was the principal investigator for the Boston Latino Eye Study and has presented nationally on interprofessional care, optometric education, care for patients with disabilities, infection control, billing and coding, and visual health equity. In her free time, Dr. Moy advocates for children with disabilities. She is a children's book author and has written The Polka Dotted Penguin, a children's book about kindness and celebrating differences, and Dottie Meets Molly the Bully, Molly the Bully, to empower children to stand against bullying. Our second speaker, Dr. Christine Pham, was born and raised in Southern California. She received her Bachelor of Science degree from University of California, Los Angeles, and Doctorate of Optometry from Western University of Health Sciences College of Optometry. Throughout her education, she has earned academic excellence awards and service recognitions for clinical excellence. Upon graduation, Dr. Pham completed her residency in primary eye care and geriatrics at the Edith Norris Rogers Memorial Veteran Hospital in Bedford, Massachusetts. After working in private practice and ophthalmology group practice, Dr. Pham joined faculty at Western University of Health Sciences College of Optometry in 2015. Dr. Pham is an instructor of record for clinical skills and procedures for the anterior and posterior segment. As a clinical instructor at Community Health Alliance of Pasadena, or ChapCare, by unmet, Dr. Pham provides comprehensive eye care alongside third and fourth year optometry students. Her clinical interests include ocular disease and ocular manifestations of systemic diseases. She's a fellow of the American Academy of Optometry. And with that, I'll go ahead and kick it on over to Dr. Moy to start us off.
Sorry about that. I'm using someone else's computer and find the mouse arrow. I'm Dr. Moy. Thank you so much for being here. I'm honored to be here today to share about our partnerships with community health centers to provide eye care access. First, I'd like to review what optometry is, and then the question I often get asked is, what are the differences between optometry and ophthalmology? So first, let's review the definition of optometry, which is that we're essential healthcare providers. We're recognized as physicians under Medicare. We examine, diagnose, treat, and manage diseases and disorders of the eye. We also play a major role in an individual's overall well-being by detecting systemic diseases in the eye and diagnosing, treating, and managing ocular manifestations of those diseases. And we can provide vaccinations as well. Next slide. So here's a little chart to simplify the difference between optometry and ophthalmology. Optometrists are the first line of eye care for eye health. We do the routine care. And ophthalmologists are medical doctors for complex eye conditions. In fact, if I find something that needs more complex medical care, I would refer to an ophthalmologist. Optometrists specialize in refractive error, like if they need glasses, and also routine eye care. And then an ophthalmologist will specialize in eye disease and are able to perform more surgeries than optometrists. For optometrists to become certified, we have 4 years of optometry school after college and an optional 1 year of residency. Ophthalmologists do 4 years of medical school and then 4 to 5 years of additional residency and fellowship. That added amount of time for fellowship training can often narrow down the number of people who are interested in pursuing ophthalmology. Optometry also diagnoses and manages general eye conditions, while ophthalmology manages complex cases such as retinal and neurological cases. In optometry, we can specialize in low vision, pediatrics. You can see the list here on the right, specialty contact lenses, primary care, dry eye, myopia control, glaucoma, and eye care for intellectual and developmental disabilities. We're now able to prescribe systemic medications within a certain area, but ophthalmologists may prescribe medically for systemic disease as well. Next slide. So the scope of practice for optometrists varies from state to state. And if you think of optometrists as the primary care provider for the eye, the flow then goes to referring complex disease to the ophthalmology clinics. In ODs, which are optometrists, in all 50 states can prescribe certain oral antibiotics and antiviral medications to treat ocular conditions. Some states give optometrist privileges to prescribe oral steroids as well. The scope for optometrists varies by state. In 11 states now, optometrists can provide basic laser procedures. There's a link here for future reference that also details the scope of practice in the United States for optometrists. Next slide. So visual health equity is something that we strive to teach about to our students, our colleagues, and to the medical community at large. Without eye care services, basic visual needs of patients may not be met. This was really highlighted during the pandemic because it was seen that when someone could not access their eye care and they lost their glasses or their vision changed, they couldn't get in to get their prescription updated in a timely fashion, and this could impact their performance at work and school. We've also seen through our partnerships with health centers that eye care is an integral part of the healthcare team at the FQHCs. We help with diabetic management. We work together to identify autoimmune disease. We identify visual impairment and work with the team to make sure that someone is able to do what they need in their daily life. Hypertension is another chronic disease we help and identify in the eye. And amblyopia is a childhood vision problem that can severely impact their school performance. So these are just some of the examples of why we strive for equitable visual health. Next slide. I don't have one for the country as detailed, but I wanted to just kind of show you how it is in Massachusetts. Massachusetts, in relation to the rest of the country, is rich in eye care clinics and community health centers. So we have 51 community health centers in Massachusetts, and of those, 23 have eye clinics. And that's 45% of the Massachusetts health centers that have eye clinics. So you would think, oh, we're pretty rich in eye care. But I plotted it on this map. And if you look at the blue irises that I've planted on the state, you can see that there are eye care deserts in the middle of the state and in the southern part of the state where those health centers do not have eye care services. And so those people have more trouble accessing those services to give them the help that they need. And it's even worse in the rest of the country. Next slide. So just to get a little more into the training process that someone goes through, it does require a bachelor's degree to enter, and there's an entrance test as well for optometry school. There is a 4-year optometry program, but also 2- and 3-year accelerated programs. At our school, it's for international optometrists and also PhDs in science to use the accelerated program. The optional 1-year optometry residency is different from a medical residency. It's focused on optometry and the specialty at hand. So when we have our students side by side with medical students, we have to kind of define how they are more able to do eye care procedures early on compared to medical students who might be in more of a shadowing role at first. In addition, there's an optional fellowship. Some will go on to specialize in low vision rehabilitation or ocular disease and go an extra year. Next slide. So just to give you some data to further illustrate how much eye care is needed, per HRSA data in 2022, there was a total of 1,372 unique health centers, and optometry was present in 36% of those health centers. Ophthalmology was present in 9% of those health centers. And overall, less than 3% of the community health center patients, 31.5 million of them, receive eye care. And so we can do better. We need to combat age-related macular degeneration, cataracts, diabetic retinopathy, and glaucoma. Most of these, well, these are all preventable, but some are even more preventable than others. There is a lot of disparities in the access someone has for cataract surgery, for instance, which is a preventable cause for blindness. Next slide. I took these maps from the labor department. You may be wondering, how much does it cost to hire an eye care provider? There's quite a difference between salaries. you can see from the map here the annual mean wage. And for the most part, there's a lot of, there's some dark blue, but maybe the medium blue. So it looks like more about the 243,000 to 343,000 range as an average. Optometry, the average is $132,524. We took that from Eyes on Eye Care, and there's also the ACU report as another resource. So you can see that there is a difference in investment, and some health centers choose to hire the optometrist as a cost saving, but that one that balances the well-being of their patients. Next slide. So to go further into detail about our partnership models with health centers and the New England College of Optometry, we have more than 500 students and we need placements for all of them. It's a 4-year program and we have second, third, and final year student placements. And so we've been partnering with community health centers in the Boston area since 1972 so that we can have a synergistic relationship and have our students placed to learn how to be optometrists while addressing the eye care disparities in Boston. So our mission has been to provide comprehensive eye and vision care services to diverse populations through our proven leadership in optometric education, research, and community collaboration. Next slide. So here's just a map to just show you, we're very concentrated in the greater Boston area, but we've gone out a little bit. And we tell our students that we have a distributed clinical network. We have early and diverse training, diverse practice settings for sure. They have exposure to specialty care at some of our community health center sites. We have low vision, we have specialty contact lenses, and we have pediatric specialists. We have very diverse patient populations. You might see someone in South Boston who's Albanian, and then across town, you might go to my clinic where a lot of them are Dominican and Puerto Rican. So our students get exposed to different ocular conditions that come along with people from diverse backgrounds. We teach them culturally inclusive optometry and how to provide culturally safe environments for the patients. We expose them to social determinants of health, and we model interprofessional practice. Next slide. So this is just to show you that we have several types of partnership models. We have full contract models, we have partial contract models, and minimal contract models. Our full contract means that we send and assign 1 to 4 health center faculty to go to the health center, operate and direct the department, have the interns there, and we basically run the department with some administrative support from the health center. The health center keeps the revenue, and we're able to provide a teaching center for them. There are partial arrangements too, where maybe the director of the eye care department doesn't work for us, but some or all of the other faculty do. And then some just have students from us, and we have minimal faculty involvement. We also serve as consultants for some of the sites, maybe to discern viability or to give advice on equipment purchase and space issues. Our final year students, by the way, are required to do a rotation in a community health center. That helps them to be more well-rounded, more culturally sensitive, and that enables us to see more patients in a health center. Next slide. So this kind of says what I just said in the other page, but the ability to see multiple patients per hour depends on the space and the number of interns. And so a site that has 2 exam rooms is not going to see as many as a site that has 8 exam rooms. And obviously you can think about how many interns in an 8 exam room clinic. There might be about 50 interns in a semester who rotate through. It usually boils down to more like up to 10 interns per day, but it really depends on the number of providers you have as well. We have the additional models, and what we've seen is that when there aren't students, then an optometrist has to choose between having an optometric tech or doing direct care. Doing direct care means less volume without having a technician. The technician can start the eye exam procedures for the optometrist so they can jump back and forth between rooms. But honestly, without the students, I think our productivity would dip quite a bit. Um, and then optical has been a key investment for us. The health centers that have opticals, that can often be the deciding factor in how profitable the department is. So if someone were considering an eye clinic, I would definitely suggest that it involve an optical and doing it well so that it's not just a closet, which I started with personally, but something that would invite people to purchase. It also provides the ability to comfortably dispense Medicaid glasses if that's something your state has. The other thing about equipment purchasing that we've seen is that health centers that have existing spaces or have decided to build an eye clinic without the input of optometrists, or especially the optometrists who will be there, mistakes tend to be made because maybe there's less awareness about what the Board of Optometry requires in terms of sinks, and maybe functionally there's not as much awareness as light placement and outlet placement and light switch placement, and then what equipment needs to be purchased in general. So I definitely just want to encourage anyone considering that to always have a consultant at the very least in place, if not the optometrist who will be going in. Next slide. I would be remiss in not mentioning the Primary Care Association partnership that we have with the Massachusetts League of Community Health Centers, led by Michael Curry. Our partnership dates back to the 1970s as well. And there's multiple ACOs within the Mass League, and we contract with many of them, and we have strong mutual support. I go to all their functions, they go to ours, and it's just a really strong relationship that we have with them. NAC was able to bring us together with the Mass League to write a white paper on the partnership that we have together. And that's definitely a great resource to read more about our partnership. Next slide. So wrapping up is the description of our Student Community Health Center Club, which is the first student health center club for optometry in the country. And we have monthly speakers, we have opportunity for recruitment for health center residency and jobs. And all of this is to kind of set up a pipeline to get them excited about choosing a career in community health center optometry, and then hopefully getting them to choose a residency in community health, and therefore making it very natural for them to choose a career at our network or another network that has health center optometry. So NECO has 4 community health center residency, and UC Berkeley has a primary care health center residency. And so this is just the start. We hope to have more, and all the optometry schools are trying to work together to really make it gel, to have this more of a movement. And I think that's all I have, and I'm going to turn it over to Dr. Pham.
Thank you so much, Dr. Moy. All right. So Dr. Moy did a very good job highlighting the differences between ophthalmology and optometry, and then just giving a brief overview of how these schools are integrated within the community health centers. I hope to kind of give you a little highlights because I myself was sent to these community health clinics to kind of jumpstart their vision service. And so I hope to share some of the challenges and limitations that I actually ran into. Next slide, please. So really briefly, Dr. Moy and I represent 2 colleges of optometry that's on either coast. So I'm based out on the West Coast. Dr. Moy is represented at NECO, which is on the East Coast. But currently there are 23 accredited colleges of optometry that are dispersed around the whole entire United States. And each college is ran a little bit differently. Western University is actually a health science university, meaning that there are currently 24 academic programs that are being represented. So we have a College of Nursing, a nurse practitioner school, podiatry, dental medicine, osteopathic medicine. So as you start doing your research and kind of understanding a little bit more about the differences of all the different colleges of optometry, there might be integration of the other programs that are affiliated with the same healthcare university. So whenever you start to see the word WUCO, that stands for Western University College of Optometry. So our mission here, you guys can read it for yourself, but I wanted to emphasize that we are related into interprofessional education. So what that means is that we train our students to be integrated into an interdisciplinary and then a team-based learning. So we have a lot of discussions based upon interprofessional education. So the goal of Western University is that it helps allow our students to enable effective collaboration to improve healthcare outcomes. College of Optometry in particular, our core value here is committed to professional collaboration, community involvement, accountability, and integrity, as well as respect. And so what better model to do to incorporate our students into community health centers? So our school, Western University, started in 1977. In 2009, the College of Optometry was started and founded. And after 2009, we started developing our relationships with community health centers. Next slide, please. So unlike the East Coast, the West Coast is a little bit more spread out. There's, there's certain pockets that are a little bit more rural where access to healthcare is a little bit more limited. When you're more integrated within the city or major cities, there's a lot more representation. So the pins that you have here is the where Western University is located. So it's located in a town called Pomona. And our relationships are kind of spread within a 35-mile radius. So what I want you to kind of keep in mind is just this mental visual of where some of the students might have to travel. So unlike the East Coast, where certain certain community clinics might be accessible through major transportations like the subways or the trains. In Southern California, most of the students have to drive. So our first clinic that was negotiated with our school was located in Pasadena. That is now our Chap Care, now owned by Ultimate. The first location had a full-time clinic, and that clinic was so successful in terms of vision care that they decided to open up a satellite clinic that's open 2 days a week. So in 2015, that was started. In about 2018, our satellite clinic was started. We saw that this was a great need for our students and that they were getting a lot of great care, a lot of complex cases that were under their belt. So we decided to open another community clinic down in downtown LA and one that's pending now in Riverside. Next slide, please. So 2 different types of partnership models. The first one is similar to what Dr. Moy had mentioned, is that it's a full contract model. And so this the school administration, part of College of Optometry, is sent out to be consultants. And as the consultants is helping the community clinic, we are kind of providing resources and tips on how to kind of create this exam room so that way it adheres to quality assurance as well as compliance. So for a full contract model, the clinical faculty that is being represented to the healthcare clinic is staffed solely by WUCO. We then will provide 3rd and 4th year interns to staff the clinic, and these clinical faculty will serve as clinical directors. So if your community health clinic does have these subcommittees, our clinical faculty is going to represent on behalf of the vision services. So they'll practice on quality assurance or practice management, chart reviews, anything that you would have as subcommittees. Now, students will be sometimes on fall break or winter break or summer break as well. So in the event that our 3rd year students are in finals week or not able to staff the clinic, our clinical faculty will serve as direct care when students are away. Now, with the full contract, the clinical faculty is there 5 days a week and with administrative support from the Community Health Care Center. And as Dr. Moy had mentioned, that the number of encounters based upon number of total exam rooms. So what you see on the picture that's on the right side is one exam room. So within a community clinic, We have some community clinics that operate out of 4 exam rooms. There's other community clinics that operate out of 2 exam rooms or 3 exam rooms. And so what you see here is the setup of a normal particular room. And so the limitations that I had on mine is that when the equipment was installed, it was actually installed by just random like individual facility management. And so nothing was calibrated to actual eye vision care services. And so I think that it was really important to kind of integrate, consultants from our school. So that way we have eye care professionals that are actually servicing the equipment. Next slide, please. In comparison to a full contract model, perhaps the community clinic doesn't really have space or is pending space available for vision services. Or perhaps you wanted to kind of just trial what vision service is like and then be able to kind of create a vision care clinic based upon what your observations are. So Western University does provide this per diem contract where it is part-time or just one day by day or even a half time. So it's staffed still by clinical faculty that's part-time. Usually these are third years that are provided because it's not full-time for a fourth year student, and no direct care is available by clinical faculty. Usually this model operates 1 to 2 days a week or even a half day depending on the needs of the community health service. The equipment here is, instead of being a permanent equipment that's built into an exam room, this is a setup mobile van type of situation. So what you see on the pictures on the right-hand side is that we have a van that provides portable equipment, or also an RV that provides an exam lane that will be able to kind of service the people that are within the community health service. So the limitations on this is that the number of encounters will be slightly reduced based upon the setup and the breakdown of the equipment. So if the community healthcare clinics, the FQHCs, don't have funding for the particular equipment, we will bring out our own and be able to kind of service the town. So what you see here on the top right picture is something called a phoropter. It allows us to measure the prescription out of somebody's eyes. And what the students will do is that we will set up this equipment, break it down, and just make sure that it's calibrated to either 10 feet or 20 feet based upon the rooms that we have here. The models that is best described on this is there are some partnerships with community health centers where maybe a particular specialty is only operated half day. So we'll just take, gynecology and obstetrics. Maybe they are only serviced there 2 days a week, and perhaps there could be another placement for vision service to take over their room. So there was one model that we had in downtown LA that we actually shared rooms. So while the specialty was not there, we would go in, utilize their room because it was calibrated to a 10-foot room. We would set up all of our equipment, be able to kind of see our patients, still utilize their electronic medical records, and then break down our equipment and then basically bring it back home. And so it was not a disturbance to the actual facility, just because that room was only operated by a different specialty only 2 days a week. So then our team decided to come in and be able to kind of use those other rooms 2 days a week to kind of make sure that we're making best use of our space. The bottom right picture is an RV. So the school does have a mobile van where we are able to kind of bring out equipment and set it up in the exam rooms, or we can park this really large RV where it has 2 or 3 exam lanes that we can bring the patients onto the RV itself and be able to kind of examine our patients. So I would encourage you to reach out to the nearest, optometry school that you have. Most of the optometry schools do have these mobile vans equipped on their sites that they can go out and be able to service. Next slide, please. So as we had mentioned before, I know sometimes it's hard to kind of understand the level of involvement with our 3rd and 4th year students. So I hope to kind of describe the differences between the academic clinical knowledge of our 3rd year versus our 4th year students, and then also kind of bring it back to the location map that we had earlier. So a 3rd year student is still currently enrolled in academic classes. So they still are going back to school, learning some of the skills, some of the critical thinking, also didactic knowledge on campus, in addition to seeing patients 1.5 days a week. So in a 3rd year student, basic clinical skills, ocular disease, pharmacology courses have been completed. So this is entry level. Some higher level advanced clinical skills are introduced, but not necessarily practiced. With these students, their clinical assignment is 1.5 days a week. So which is why when we staff our third-year students with the community health center, they are limited because they are only there 1.5 days a week. And so transportation is something that is very, very important. They must go back to school some days to be able to attend classes. Now, these students require a little bit more supervision because this is their first time actually conducting a comprehensive eye exam independently. So when you're thinking about carving a schedule with these students, sometimes these students will take a little bit more time in order to examine your patients. So this is something to definitely consider as the number of encounters that a particular student will see per day. In comparison, a fourth-year student, they think about it as they're in clinic full-time. It's a full-time 40-hour work week. All of their education has been completed, that they are now solely trying to develop their clinical experience, being able to kind of understand how to deal with complex cases. And so they have a higher level of critical thinking. They're able to examine a patient a lot more readily, and they are assigned to a clinic about every 3 months. So you will have the same students for about 3 months, and then after that, they will relocate to a different clinical assignment every 3 months. Currently, the relationship that Western University has is that they send their students to 5 different clinical community healthcare clinics, rotations that are clear across the United States. So unlike NECO and Dr. Moy, that it's a lot more integrated. So our goal is to hopefully develop more clinical rotation sites in the future. Next slide, please. So future direction here, again, we are a relatively newer college. We were opened up in 2009. We like to have a more robust clinical experience with our students. And going back to our mission statement with interprofessional education, we hope to increase our partnership with community health centers in the future. We have one pending right now that is projected to be completed by the fall of 2025. We also have clinics that have satellite clinics. So with Ultimate right now, we have our main campus, but there's also many small satellite offices that are dispersed through the what we consider the San Gabriel Valley. So we hope to open more campuses with vision services in the future. Again, as we are slowly kind of learning more about residencies, we kind of knock on the door with Dr. Moy and NECO and how they're modeling their residency programs. And so we hope to open more residency programs in the future to kind of allow our students to receive that higher education. All right, next slide, please. So Luke, I think we're going to go ahead and open it back to you. We can go ahead and start our moderated discussions.
All right. Well, thank you both, Dr. Moy and Dr. Pham, for all that great information. Let me pull up our next point. Now that we just pull down the slides here, give me one moment. So firstly, we talked a good bit about, getting started with vision services and how to do that, how to partner with optometry schools. Could you tell me a little bit more about why it's advantageous? We discussed it very briefly early on, but why is it advantageous to engage or partner with an optometry school when, taking those first steps towards establishing an eye clinic? And Dr. Moy, I'll go ahead and turn it over to you first.
Sure. So I did mention about the equipment and how purchasing it, you don't want to waste tens of thousands of dollars buying the wrong equipment or placing things in a place that doesn't make sense. The other thing is that having a good consultant or school partner can help you understand the Board of Optometry requirements in your state, as well as the scope of practice. And then schedule templates for optometrists, they're different than primary care or other medical specialties. And so we might book somebody every 30 minutes, but that doesn't mean that the appointment only lasts 30 minutes, because eye dilation drops are included. And so someone has to sit in the waiting room for 20 minutes waiting for the drops to work while we stack in another patient as we're waiting for them to dilate. So there are different nuances to how to schedule optometrists to maximize productivity, and that's something that we advise an optometrist be able to help with.
Thank you. And Dr. Pham, could you add some perspectives to that as well?
Yeah, so I think that in addition to kind of just equipment in general, you want to think about other nuances, software that optometry uses. So sometimes if we wanted to integrate ourselves into your current electronic medical records, is there existing templates that exist within, let's say, Epic or NextGen or any other electronic medical records? That's where our school can kind of help and step in and be able to kind of be consultants to help you maximize your workflow, because sometimes we don't want our providers to be bogged down by just the nuances of electronic medical records. We really want to kind of make sure that we're maximizing our time and in examining our patients, because patient care is really that our priority. And so kind of just stepping into becoming like a super users or understanding, or maybe perhaps our College of Optometry, our super users in IT can kind of step in and help community health centers. In addition to that, we talked about software. So if we're thinking about our patients and making sure that it is what we consider a one-stop shop, that they're able to kind of receive all the different services. Sometimes when we want to refer our patients to ophthalmology for continuity of care, sometimes based upon their insurance or even location, it's very far for our patients to kind of go and receive these specialty services. So optometrists, depending on the scope of practice of each legislative state, sometimes we're able to manage certain conditions for longer, before we actually have ophthalmology intervene. And so if we're thinking about software, how does the particular special testing that we have, interface with the current, IT that you have on your community health center? Also billing and coding, that's something that is huge. So if you want to maximize certain encounters and making sure that you get a check mark for doing a diabetic eye exam or being able to do photography and saying that you did a retinal examination, we really kind of assist you on how to kind of integrate that into your workflow.
Thank you so much. And the billing and coding piece being so important and making sure you get the funds there, have a sustainable program. Before I jump into the next question, I did see a question come in through the chat I wanted to go ahead and jump into. But what makes a community health center attractive to partner with an optometry school? Do you feel a school would want to partner with a community health center as a very established vision program, or would it be better to grow the program together? Great question.
That is a good question. I think as I personally look for places to partner with, I want to see a lot of motivation on the administration's part to bring in eye care, but in addition to that, the ability to provide space is huge. We've had some people come to us for consults about starting eye clinics, and then come to find out when they meet as a team, well, we actually don't have the space for that. So space is really great. Proximity to the school is really important. And I've seen some of the ones that have grown from scratch. It might have taken 5 to 7 years for it to come to fruition. But when it is built and it's built well, it's wonderful. And there's one in Lowell, for instance, that we helped to consult on, and it's just amazing. Has 8 lanes, has 4 doctors. They get them in and out, and the beautiful optical, and just really serves people well. With an existing one, though, we can assess what's going well and what's not, and give advice on how to have better best practices and optimize productivity and revenue. So I think they're both doable. I would say space is a very huge limiting factor.
I'll go ahead and add on and speak about goals and expectations. So the community health center that I started in, it was started as a consultant, and we started from the ground up. So just essentially what Dr. Moy had mentioned, that it was slowly developed, that the vision, the dean of our current school reached out to the community clinic and said, is there a need? Because we see that it's possible that you're sending out and referring all your patients out, but you can keep these patients in house and then, increase your encounters by developing a vision clinic. So this was something many years in the making until the contract really went through, because the goals and the expectations were mutual between both parties. So it was a shared goal that they wanted to increase their amount of encounters and be able to kind of serve their population from the school as well as the community health center. Another thing that makes it attractive is that keeping in mind that this is a teaching institute. And so sometimes when we are presented with a partnership, the demands of how many encounters the community health clinic wanted the school to see was not realistic based upon a clinical model, a teaching model. So I think that one of the things that is attractive is a shared goal as well as realistic expectations. Another thing to kind of keep in mind is where we are right now. They also take, I think, pharmacy residents as well. They have a clinical pharmacy program. And so I think that as long as there's other, potential avenues for education in other departments, that also can kind of help you tap into schools and say, all right, well, at least if we're already affiliated and we take interns from this other program, maybe try reaching out to see if they have a vision clinic and be able to kind of partner up with you.
And just echoing Rachel's comment in the chat, thank you both, very insightful feedback. One other question, thinking if a health center wants to start up their own eye clinic and they're looking to, recruit optometry students down the road, what's a way that the FQHCs or the health centers can cultivate interest among optometry students in future, for
We just lost
future
your
career
sound,
opportunities?
Luke.
Oh, am I still there?
Can't hear you.
Okay.
I'm able to hear you just fine.
But I'll go. Right. Like I mentioned before, we have the Student Health Center Club. And then we also, in that health center club, towards the end of the year, we have an event where we are actually inviting health center doctors from other parts of the country to speak about their experiences, and then showcasing some of the job opportunities that are available in other health centers that we're not contracted with. They might be in New Mexico or Michigan, or and we just kind of broadcast that out for everyone, and hope that we start to spark an interest and help people to see that these job descriptions can be just as attractive as careers in industry.
I'll go ahead and add to that.
Go ahead.
So when our fourth year students come to graduate, they have a week that they call a capstone, where all the students kind of come together and they essentially they have presentations on job opportunities, how to pay back their loans, what happens after they graduate and next steps in terms of licensure. And so there's like a whole week based upon, just what are the next steps. In that capstone week, we do have presentations from a lot of different places that have offered job opportunities, namely something called a group called Kaiser. We also have a lot of retail like Walmart, CVS's that kind of market their services and kind of make things attractive for a new graduate. If they're not moving on to their residency, what is their next steps and how do they obtain a job? One of the things that is underrepresented is actually FQHCs. And so I think that that's definitely an opportunity missed, that in the event that a community health center wants to kind of market, vision service and be able to kind of hire an optometrist out of school to be able to work at these community clinics, definitely reach out to the school and see if you can kind of tap into their fourth year capstone, because as they come back and they start learning new opportunities, they might kind of go back and say, you know what, as a fourth year, I did rotate at this community clinic and I had such a great experience. This is something that I've already exposed to, so maybe I can just kind of chase this route and have this as my future career opportunity.
Thank you both. And what do you think, or what's your opinion on what can make a job more attractive for these, new or recent grads coming out and looking for a job in an FQHC?
Do you want to start, Christine? I keep going first.
Sure. Okay, as a new grad, one of the things that they're looking for is, job security, stability. Especially in California, it tends to be very saturated. So most of the students have to pair part-time jobs in several different locations to be able to kind of create a 40-hour work week. Another thing that they talk about is benefits. And so if they're pairing up individual jobs, part-time here, part-time there, most of these students will not be able to have any benefits. So we're thinking about health benefits, maybe 401k and retirement benefits, and then something that we consider public service. And so there's a lot of individuals that are trying to figure out ways to pay back their loans. Once they maximize their loans, one of the first thing is, well, I got to pay them back. So certain things in terms of making the job more attractive is obviously full-time. If you're capable of providing a full-time job opportunity, benefits, medical and dental, a 401k, retirement salary, and then if there's any perks out there to kind of help them with their loans, because usually students are they're struggling a lot in order to pay things back, and especially in Southern California where they're trying to piece together a full-time 40-hour work week.
Um, so I think Dr. Pham said it pretty well. I'll add that at NECO, we have this program called Sponsored Pathways, and various industry companies have decided to fund maybe 1 or 2 years of a student's graduation, optometry career. And so that feels more immediate than loan forgiveness. In return, they owe that company, wherever they're assigned, 1 or 2 years of service in that organization. It's harder to do that with a specific health center, but if there's a way to invite someone to have interest before they graduate, and if they're from the area, and you've met them, maybe they can have an opportunity to get to know the health center better, and kind of plant that seed so that they might choose to live in the area and consider health center optometry. When the salary is competitive and there's ways to advance their careers, they might go from an attending optometrist to a clinic director, for instance, or within the health center, there might be opportunities to share committees, be in charge of some kind of outreach, things like that. That can help a lot to make it more attractive.
Thank you both so much. And one question, when, if a health center opens up a job for an optometrist and looking to hire them, what are some questions that an FQHC can ask to get a better understanding of their community health training experience, understanding of social drivers of health and equity, things like that? And Dr. Moy, I'll go ahead and turn it over to you for that question.
Okay. Yeah, we are, I wouldn't say flooded, but it is a very steady trickle of requests for our students to be placed in people's practices. And then we also get asked, can you come and put your doctors in our health centers? One consideration we have is the proximity to our school, because somebody may have clinic hours in the morning, but then in the afternoon, they need to get to class or to teach a lab. And so that's a very big consideration for us, is how close are you, and is there public transportation? The other thing is administrative support, making sure that the health center would be able to provide sufficient front desk and optical support. In many of our health centers, we don't hire an optician. The optometrist actually supervises the fitting and dispensing of the glasses with the interns, and maybe an optical manager or optical assistant that is trained, because there's a shortage of opticians in our area. It's so bad that we just decided to pivot and train optical assistants under the guidance of the optometrist. Something we've learned the hard way is that if the chief medical officer of the health center is not on board with optometrists and their usefulness to the patient's overall well-being, it's really hard to advance in-house referrals, advance QI indicators for diabetes or children's basic vision exams. And so the medical team really needs to be on board and excited about the addition of eye care. We have many success stories about other departments knowing that eye care was there and being able to have emergency care done for their patients, and working together. Space is important, like we said. Even the waiting room space is important. Otherwise, if the patients aren't happy waiting, that it doesn't help the overall feel. The potential for growth is also important. Even in the clinic, that the headquarters clinic at NECO, we've run out of space. And so we've outgrown the fishbowl, and in order to grow more, we have to increase the size of the building space. And so the ability to add on exam rooms is big. And just understanding that it could grow quite quickly and being able to pivot is helpful. I think I covered most of the things I could think of. Do you have any others you can think of, Dr. Pham?
No, but I think sometimes it's really it's hard to kind of reach out to the school and just you look at the directory and say, who do I call? Who do I contact? Because I think that sometimes it's almost like going to a grocery store and telling somebody, hey, pick up this, when there's so many different brands that you can choose from. And so when you're thinking about partnering up with a school, just go to your local outreach, because I know that at Western University, what we do is we do like 2 free healthcare events a year, and it's sponsored by the university. And so what we did was, that's how we got our initial contact with the community health center, because we all mutually met other providers from a community health center at this free healthcare event. And then in the event that you are just lost and you're looking on their website and you're like, who do I contact? Anybody that says clinical director or any of that other stuff, I think if you just do an initial email, they should be able to kind of put you in the right direction of just stating simply that you are from a QUHC and you're looking for a partnership with Vision Services might be kind of good. So I just wanted to kind of give that as a background, that sometimes, we look online, we try to do our own Google search, and it's really difficult to find a point of contact. We have our emails, I think, listed on the slide deck. So if you wanted to reach out to us and we can kind of facilitate that connection ahead of time, I think Dr. Moy and I are more than happy to do that. But you can also look, if there's a local community outreach event. I know that the community health centers will do these health fairs, and so that's a great opportunity to see if there's any relationships there.
Fantastic. Thank you both. And seeing that we have 1 minute left in our hour for today, if you have any additional questions, and I know there's a couple other questions we're going to get through, which we can maybe follow up, provide a brief summary or FAQ that we can send out afterwards. But if you have any other questions, please feel free to email me and follow up after this webinar. I'm going to be sending out the slide deck and the recording of today's session here in the next 2 weeks. And some other quick resources I did want to flag before we go today, but ACU has a number of different resources on our website, www.clinicians.org, and I'll send you direct links to all these. But we have a new technical assistance resource that is on billing and coding at FQHCs, so tips and FAQs, which was put out by our Vision Services Committee. We also have a networking opportunity for optometrists, which is a Facebook group called the FQHC and Community Optometry group. It is about over 300 or so health center optometrists and advocates from around the country that reach out to each other, network to solve issues, common problems, things like that, share successes. So that's always a great resource for if you are an optometrist or if you are planning to hire one. We also have our Vision Services Committee. We have applications open right now to join the committee here in 2025. And then we've recently launched the 2024 Health Center Eye Care Workforce Survey. So we are trying to gain insight into the eye care provider workforce, since it has absolutely exploded in the last 10 years. want to get a better understanding of training, education needs, things of that nature for the eye care provider workforce. Lastly, we have the second part, or part two of this webinar series, on Tuesday, December 3rd at 1 p.m. If you signed up for this webinar, you automatically get a registration for the next one. So we look forward to seeing you then. In wrap up, thank you again, Dr. Moy, Dr. Pham, for all the great insight into how your universities work with FQHCs. Thank you all to everyone who was able to join today. Like I said, we'll be sending out this recording if there's something that you might have missed or want to hear again, along with the slide deck here in about 2 weeks. Thank you all again, and look forward to seeing you on December 3rd. Have a great day.
Thank you.
Thank you.